pressure, a history of high blood pressure. Okay. Brian, give me one.
High cholesterol.
High cholesterol, history, yeah, absolutely. Okay. My guess. Oh, absolutely. Elderly population, specifically diabetics, female diabetics tend to have abdominal pain. Chris, give me another one.
Diabetes.
Oh, absolutely. History of diabetes. Give me another one, Amanda.
I know. You guys
Obesity.
Come on, dude. So give me an example of something that might cause you to have a high index of suspicion that your patient has a cardiac issue.
certain medications that they're taking.
Okay, excellent. So you look at their medical history and you're looking at the meds that they're on and you have a high index of suspicion. What kind of medications are we looking at?
Nitro, you can think of like some
Nitrates, absolutely.
warfarin, acumidin.
Okay, blood thinners. Yeah, no doubt. Okay, beta blockers, absolutely. So you see those medications, DIG, any kind of DIG, yep, absolutely. You know, you have a high index of suspicion that this patient is going to have some form of a cardiac issue. So it's really important for us pre-hospitally to have a field impression moving almost right from the very beginning. That's a really good thing to have. 2007, heart disease contributed to about 34% of all U.S. deaths. That's pretty intense. They talk to you a little bit in the book about modifiable versus non-modifiable risks for heart disease. Modifiable are things that we obviously can fix, like stop smoking, control your high blood pressure, change your sodium intake, stop having a sedentary lifestyle, lose weight, all that good stuff. And then there are non-modifiable risks. And I wanted to talk to you guys about this because we fall into type A personality traits, bless you, in emergency medicine. A lot of us emergency medical responder folks have type A personalities. Explain to me what a type A personality is, Bob.
Not normal.
You're what? We're not normal. Could you be a little bit more specific? Bob.
I don't know.
Okay, Chris, help him out.
Controlling,
high-strung, very kind of much a go-getter, very jumpy, so to speak. So yeah, a lot of us are type A people where we have to kind of be on the go at all times. Carbohydrate intolerance is another big one. Does anyone here have carbohydrate intolerance? At the very beginning of this class, back in A&P, Amanda talked to Dr. Sturgeon about someone who had a condition that had them get cysts on their ovaries, polycystic ovarian syndrome. Carbohydrate intolerance is actually a part of that syndrome. And one of the things that you will notice with these women who have this is that they can eat meat, and they can't process their carbs. So oftentimes they're bottoming out. Their sugar is bottoming out. They're constantly taking in the sugar, and it's just not processing well. So again, this is something that's not modifiable. Essentially you're born with it. Family history, if your dad died at 46 from a heart attack, and his dad died at 46 from a heart attack, and your brother died at age 46 from a heart attack, you think you're seeing 90? Here's to hoping. But probably not. Advanced age, obviously, as we get older, our muscles deteriorate, and that includes our heart. Obviously, prevention and education are a big thing. We want to have prevention and education as part of what we do pre-hospitally. Give me an example of how you might be able to educate somebody on the scene, Dave.
Providing them with opportunities to kind of treat what they've already gotten, or opportunities where they can, if they're obese and they're having shortness of breath on exertion, encourage them to exercise and
because that's what every overweight person in this shortness of breath who called 911 wants to hear. This wouldn't happen. I know, this wouldn't happen if you weren't such a chunk. I'm just saying. Okay, absolutely. So we can certainly try to educate people. Listen, it looks like, what about this? What about this? You go into those homes with the smoke, the heavy smoke, it's just hanging, and you have someone with chest pain. And you put them on the monitor, and it's relatively benign. But you have to take them anyway because they're having a symptom. They're having a very serious symptom, chest pain. That could be a lot of different things. And just because we don't see anything on the monitor doesn't mean that they're not having some form of a myocardial event. So we absolutely have to take these people seriously. Something that we might want to say on our way out is, listen, I understand you're a smoker, but opening the window might give you a little bit easier time breathing. This banked down smoke situation is going to really cause an increase of your heart to have to work. It's going to increase myocardial oxygen demand. And you can talk to people about that. Obviously, you're not going to say myocardial oxygen demand, but you might say, your heart needs oxygen to beat. And, with the smoke in here, it's going to be very difficult for you to do that. Weight management, aerobic exercise, awareness, all those things are really important. And obviously, again, we as EMS providers, we eat horribly. We're chain smokers. We drink. We self-medicate after a nasty call. As I was walking in here and starting to set things up, Amanda was talking about having to take a fetus out of a bathtub. That's pretty crappy. I don't care how you slice it. It's pretty awful. So, some people might not be able to handle it as well as Amanda, obviously. It's because she's sitting here. But I got to tell you, look at her. She's like, I'm awesome. But, different things are going to mess with different people. One of the worst calls I ever had to deal with a kid. And the kid came out okay. And I was totally jacked up. I've coded kids, and it didn't really faze me that much. I mean, it sucked, and it was horrible, but it didn't make me want to cry. The situation that I had, the kid turned out just fine, and it really messed me up. So, again, different things are going to affect people differently. And if you're an EMS, there's this weird thing, this weird kind of social status thing where you don't go and accept help from other people or seek help out. And it's the wrong way to be. We have to kind of look out for ourselves. The cardiac cycle. So this is where we get into the really interesting parts of the body. Okay, and this is really where we're going to start as pre-hospital providers taking effect and taking hold of someone's body and changing things. So the cardiac cycle, one cycle represents complete depolarization and repolarization of the atria and the ventricles. Where's the atria? If this is the heart, where's the atria? Right? Okay, and end? Okay, absolutely. What is depolarization? What does that mean?
Contraction.
Contraction. Okay, but it's more than just contraction. What is it? It's a change in charge. Yeah, very good. So in order to have, when you're talking about heart muscle, you're talking about two components. You're talking about the electric part, and you're talking about the muscle part. Okay, so you're talking about muscular force, and you're talking about electrical charge. And that's very important to understand when we use words like depolarization and repolarization. So, cardiac cycle represents one complete depolarization and repolarization of the atria and the ventricles. That means a bam bam. Okay? 1, 2. That is one cardiac cycle, and it's very important to understand that. What is Al doing to you?
It wasn't Al's fault today.
Ah. All right. Diastole. Where have we heard that word before as BLS providers? Blood pressure, absolutely. So diastole. Is that the top number or the bottom number? Bottom number. Excellent. So I always remember that as sit down. Systole, diastole, sit down. I don't know. It always works for me. So diastole is the lower number that we see. And that lower number represents the atria, the ventricles. They're resting. Okay? They have done their thing, and they are starting to rest. Systole is the atria or ventricles contracting. Okay? So it's that force. It's that traction. Okay? That's why you have that top number being larger. It's larger than the bottom number. What happens if you see a top number bigger than the bottom number? Oh. What? Maybe we need another cuff. Maybe we need another patient. I'm just saying. Right? So it's not something that we're really going to come across. What did I do with my clicker? Oh, there it is. All right, cardiac cycle. The relaxation phase. Left atrium fills with blood under venous pressure. Okay? The nice thing, let me back up. We have all grown up thinking about the heart as a single pump. They lied to you. You need to go punch your high school teacher. They lied right to your face. I'm just saying. They lied to you. It's really two pumps. Okay? You have a high pressure pump and a low pressure pump in your heart. It's not just one pump. So keep that in the back of your minds for right now. Relaxation phase is when the left ventricle fills with blood under venous pressure. Is this passive or active?
Passive.
It's what?
Passive.
It's passive. It's absolutely passive. Why is it passive?
Gravity fed.
Okay. All right, explain to me a little bit more about gravity working. Why does gravity work so well?
Well, it's related to the Higgs boson.
Stop it. All right, listen. Oh my God, did everyone see the Big Bang Theory where they said bye to Howard's mom? I was crying like a little girl. I'm just saying.
No, thanks for ruining it.
Aw, spoiler alert. Sorry.
It's already followed.
I was going to say, it was on MSN. You're fine. All right. So absolutely, it's passive. Okay? So relaxation, the left atrium fills with blood under venous pressure, and it's passive. It's a passive thing. Atrial contractions, when blood in each atrium is squeezed into respective ventricles. Atrial kick is the contribution made by contraction itself. Okay, so this is where we get kind of into the nitty-gritty of talking about the cardiac cycle and what is actually happening. The relaxation phase only takes 0.52 seconds and is a lot longer, okay? 80% of ventricular filling occurs in this phase, with the remaining 20% of ventricular filling occurring during atrial contraction. And that's that atrial kick we're talking about. Okay, that's that last 20% that's occurring. So when does a ventricular contraction begin? Okay, the ventricles contract, which causes the semilunar valve to be forced open. Okay, blood from the right ventricle is squeezed into the pulmonary artery, and the left ventricle blood is pushed into the aorta. It's like this big cycle. So here is the situation. Why are we moving this blood? What is the end goal? What do we want to do? Ed, what do we want to do with this blood?
Reoxygenate
We want to reoxygenate where?
the body.
Where do we want to get the oxygen?
Where do we want to get it from?
Yeah.
The lungs.
The lungs, absolutely. So where does our deoxygenated blood come from? Go ahead, Dave. It's killing you. Just say it.
I'm fine.
Are you sure?
Yeah.
Okay, because sometimes you get this look like your head's going to pop off, and I worry.
No,
Okay.
I have a cinnamon, so that's.
Oh, it's a cinnamon. Those cinnamons. Okay. All right, G. Where does the deoxygenated blood come from? Use your big boy voice. Can't hear you. What?
After exchanging a tap.
After what?
After exchanging a tap.
What? Okay. So all of that deoxygenated blood that's coming from all over your body has to come in and get oxygenated, right? So systemic vasculature is the right answer for that. All your deoxygenated blood is coming from systemic vasculature. It's going to come in, and we're hoping to get it in through the lungs to get oxygenated. So again, back to this two-pump thing. All right, we talked about a high-pressure pump and a low-pressure pump. The right side of the heart is a low-pressure pump, whereas the left side of the heart is really high pressure. The left side of the heart, with its high pressure, pulmonary veins collecting blood from the lungs. Is this going to be your oxygenated lung or oxygenated blood or your deoxygenated blood? Oxygenated, right? Absolutely. Whereas the right side is not oxygenated, which makes sense because it's low pressure, right? So it makes sense, just common sense-wise, to think that oxygenated blood is low pressure, right? Okay, so this makes life easy. So low pressure is your right side. Superior vena cava and inferior vena cava collect the blood. Now this is even easier, and thank God people know that paramedics and EMTs are not that, book smart. So they said that the superior vena cava collects the blood from the superior part of the body, the top part, and the inferior vena cava collects blood from the lower part of the body. Well, that makes life a lot simpler, right? So superior versus inferior, and we're taking all this blood from our systemic vascular, both top part of the body and lower part of the body, and we're bringing it in. And then where do we send it? Into the lungs. And then what happens in the lungs? It gets oxygenated. Then where do we take it? We send it out via veins or arteries, guys? Arteries, which explains why you cut your artery and it squirts everywhere and it's bright red. Why? Because it's high pressure. It's that oxygenated blood. Make sense? Life is, I love cardiology. It's so hot. Oh, love it. Yes. Preload.
Need a break? You all right?
No, I don't. I'm okay. I'm all right. All right, preload. The initial stretching of cardiac myocytes prior to left-sided contraction. So this is where, again, we get really, really into things. All right, so preload. I'm going to ask you to just kind of wait on preload, and we're going to come back to it in a second. Afterload is when blood is driven out of the heart against systemic arteries. So talk to me a little bit about afterload. If blood is being driven out of the heart against systemic arteries, what are we thinking about that? High pressure or low pressure? High pressure because it's working against something. It's working against a force. Preload, high pressure or low pressure? Probably low pressure, right? Why is it low pressure, Chris?
It's just deoxygenated blood coming in.
Good.
Or atrium, especially.
Good. Absolutely. So we almost have, because we have two parts of a pump, we almost have to have two separate circulations in the body, okay? So those two separate circulations are systemic circulation and pulmonary circulation. So all blood vessels between the left ventricle and right atrium are going to be systemic circulation. And then all the blood vessels between the right ventricle and the left atrium are going to be pulmonary circulation. Okay, does that make sense? Because again, we want our pulmonary circulation to start oxygenating blood. And we want our systemic circulation to handle bringing all that blood back in from the big wide world of our body to make sure that it can be oxygenated. So let's talk about how our two separate pumps work. Okay? Excuse me. So skeletal muscle and thoracoabdominal muscles, they actually aid the pump to send venous blood back to the heart. And this is where we start our introduction into cardiac output. And I forgot to write this up on my cheat sheets up here. Cardiac output equals stroke volume times heart rate. That's your next tattoo, those of you who like ink. Okay? That's your next tattoo. You have to know that because it's going to be on everything. Every test, every national registry question. When you close your eyes at night, it should be the last thing you're thinking about. You should be dreaming about cardiac output. On your tombstone when you die, it should say CO equals stroke volume times heart rate.
But the only thing that we can measure pre-hospital is heart rate.
It's gonna be on every fucking test ever. I don't know why. It's recorded, that's why I'm whispering. Okay? Every national registry test I have ever heard about, they ask you like 8 questions on cardiac output, and they want to know different variations of this junk. And they're going to give you numbers to plug into this crap, and they're going to want you to know it. So this is one of those really important, stupid things that National Registry is going to want you to know that there is absolutely no freaking reason for you to know. Write it down, take a picture. All right, heart rate, number of contractions per minute. It's your pulse. Oh, sorry, kids. So cardiac output is the amount of blood pumped by either ventricle. Stroke volume is the amount of blood pumped by either ventricle in a single contraction. Okay, so you're only talking one contraction. When you're BLS, you talk about pulse rate. When you're ALS, you talk about heart rate. They're different. I know, I just shattered your worlds. I'm sorry. But your pulse is different from your heart rate. And because of this thing that we talked about earlier, where when we're talking about myocardial function, we're talking about electrical activity and muscle activity. They are now different. They are not the same thing. Heart rate is different than pulse. Ejection fraction is a percent of blood leaving the heart on each contraction. Okay? Now, think back to pulmonary, when we were talking about pulmonary. And we talked about your inspiratory reserve volume, or inspiratory reserve volume. It's a similar thing when we talk about your ejection fraction. Just because the percentage of blood leaving the heart in each contraction is measured as your ejection fraction doesn't mean we're pumping everything out. There's still reserve in there, and we're going to talk about that in just a couple slides. All right, here we go. Here we go. Take a picture, write it down. Cardiac output equals stroke volume times heart rate. So here's the thing. Your heart has to work by demand. Okay? This has to maintain, these two-pump system has to maintain your body in whatever condition it comes up against. Whatever you throw at it, whatever your body needs, your two-pump system has to make it work. Because we need to maintain what, Mayor?
Circulation of blood.
Our body struggles to maintain what?
Homeostasis.
Homeostasis, right? Our heart rate, or our heart, our two-pump system has to maintain homeostasis, just like everything else in our body does. So how are we going to change to meet our increasing demand, okay, of our body? Well, a couple different things, okay? We can increase our output by increasing our stroke volume. How many times our heart actually pumps, right? Okay? Or how much is being pumped, rather. Or we can increase the rate. How many times our heart pumps. Or we could do both. We can increase the volume that's being pumped as well as the rate. So there's 3 different ways up there. that we can train our heart to kind of increase what's being pumped to our body and supplying us with oxygen. Okay? So cardiac output equals stroke volume times heart rate. Cardiac output also equals heart rate times stroke volume. That's on registry. And then wait, here, I'm going to totally blow your minds. Stroke volume equals cardiac output divided by heart rate. Whoa. Holy crap. Okay, I know, shocking. Shocking, but I'm telling you, it's going to be like 8 questions. Just know it. All right. So let's talk about Frank Starling. Frank Starling is my darling. And let me tell you why Frank Starling is my darling. Okay, because this is awesome. How many of you guys like to have balloon fights? I'm a big balloon person. I was born in the end of June. Okay, so as a little kid, all of my birthday parties, did I miss something? Did you like have a balloon fight when I wasn't here? Because everyone turned and looked at you.
So I was very confused. What's a balloon fight? That's fair.
A balloon? You've never had a water balloon fight?
Oh, you didn't say water, you said balloon fight.
You did say balloon. You didn't say water.
Well,
Yeah.
what the hell else are you gonna fight with? Like a air balloon? You can't have a fight with an air balloon. You people, what is wrong with? Is that a Montgomery County thing?
Born in June.
Whoa.
All right, water balloon. You know what? It could work with air too. Fine, whatever. When you take your balloon and fill it whatever the heck you want, Jello, water, sand, whatever you got around the house, okay? No. Okay? You're going to stretch it. You're going to stretch that balloon out. The more you stretch your balloon, what happens? The more you stretch your balloon, the more force is going to be behind it when it breaks. Okay, your heart is kind of similar in that. The more stretch that your muscle has, the more forceful the contraction is going to be. So the more we stretch your muscle, the more force is going to be applied behind that contraction. Okay, so knowing that, what do we know we have to increase our contraction? We have to increase our what? In.
The volume in the what?
Which we call?
Stroke volume?
No.
No.
Someone help Ian out. Preload. Very good. Absolutely. So if we want to increase the stretch, we have to fill the heart more. If we want to fill the heart more, we have to send it more blood. Where are we getting more blood from? Systemic vasculature. So is this blood going to be high pressure? No. That's why we need so freaking much of it, right? We got to get more blood from systemic vasculature and preload so that we can stretch our muscle out and it can forcefully contract. And that is going to actually move us along, and it's going to increase the amount of blood that ultimately we're able to have access to that's going to be oxygenated. If heart rate is constant, any stroke volume increase will increase the overall cardiac output. Does that make sense? Are you guys with me? We're learning cardiology, holy crap!
I would trust your word.
But
We're having
would
a hard
that-
time not.
would that- So that's affected, like, if you're, like, hypovolemic or something, because
Yeah.
it's not coming back.
Yeah, absolutely.
And then, even though it's still pushing that hard, your
Yeah.
SV is going to actually decrease, even though the heart rate's staying constant.
Yeah. Yeah, I mean, and that's really where you get your trauma patients. That's where they fall through the cracks. Because there's only so much we can do. They don't have the volume.
Right.
They just don't have the volume. You know? It's insanity. All right. So that's, enough about Frank Starling. All right, so preload is influenced by the blood volume returning to the heart. More blood is returning when more oxygen is in demand. So again, we know that if we have an increase in demand, we're going to have to start supplying a little bit more quickly our heart with deoxygenated blood so that we can then get it oxygenated and then back out to oxygenate everything that we need to have oxygen to be able to function appropriately. So just kind of stepping out of this slide for a second, let's talk about our nervous system. What nervous system, what part of our central nervous system is going to be in charge of ensuring that we have what we need when we need it? Say it again. Okay. Can you be a little bit more specific?
Sympathetic.
The sympathetic portion of your autonomic nervous system, absolutely. Why? Because you're sympathetic to the fact that you're going to get your ass kicked if you don't have enough oxygen fueling you so that you can fight or flight. You can fight or you can run away. Absolutely. Okay. So more blood returning again is going to increase our stretch back to Frank Starling, and we're going to be able to get a more forceful contraction, and we're going to increase our cardiac output. The degree of the contraction can vary without change in contractility. Okay, this is a little bit more difficult to understand. With a constant stroke volume, cardiac output can increase or decrease by the number of contractions per minute. So again, this goes back to this whole thing where when we're talking about the heart, we're talking about electricity and we're talking about muscle. Okay, they're very different things. When we're talking about the ability to contract, we're not talking about the actual contraction itself. And this is where people get lost in cardiology and don't. Okay, you have electricity, you have muscle. They're different. You can have a heart that's perfectly fine electrically, but is not making the heart beat muscularly. And just like I said, and just like that, now you have something that's broken. You have a heart that's not working. So you have to have both of these things working, these two-part system of the heart, the electricity portion and the muscle working. Just out of curiosity, and again, it has nothing to do with the slide, nothing what's up there. I'm just asking you to think ahead. If you have a heart that has electrical activity, but it's pulseless, do we know what we call that rhythm?
Yeah.
Which is? Pulseless electrical activity. See, cardiology is so easy. Okay? And the cool thing is, it can look like anything on the monitor. Anything at all. Any freaking blip, bloop, whatever you see on the monitor, all right? If they don't have a pulse, it's pulseless electrical activity. It could be supraventricular tachycardia. It could be atrial fibrillation. It could be a junctional rhythm. If it doesn't have a pulse and it has waves, it's a PEA. In fact, VTAC and VFib are forms of PEA, pulseless electrical activity. So you're going to look really super freaking smart when you go out and you say, oh, well, it's obviously pulseless electrical activity, you know? And it's easy. It takes like 2 seconds. Why? Because they don't have a pulse, but they got blips. That's pulseless electrical activity. I just taught you like freaking 30 different dysrhythmias in like a matter of a half a second. You're welcome. You're welcome.
I like how you get gangster when you start talking about that.
What kind of gangsters are you around? That was like an old New Yorker for me.
We're so close to Trenton.
I'm like, oh my God. And you're like, wow, you're a gangster. I'm like, wow, no, I was from Rhode Island. I don't know what happened there.
Yeah, talk to G.
G, are you from Rhode Island? I'm confused. Okay. So there's a word up there that we haven't talked about yet, and that's chronotropic. So back to what I was saying initially, your heart has multiple effects now. You have electrical activity, and we can talk about your rate of your heart and force of the contraction. What's chronotropic sound like? What's chrono sound like?
Time.
No, it sounds like chronos, which is time. Come on, man, you missed a whole step. Chronos is time, okay? So chronotropic is positive chronotropic effect is increasing your heart rate. I'm just saying, doesn't that? Yeah, it's Latin. Chronos is a Latin for time.
Gotcha.
Sorry.
Did anybody play Chrono Trigger? I mean, really?
What?
Video game from the 90s.
Listen, Buffett.
Chrono
You're on your
Trigger.
own with this one.
Oh, honey, I think you just showed everyone your age. Okay.
My watch says chronometer.
There you go. See?
Usually people have time things, time slips that say Chronos.
Oh, there you go. Time slips that say Chronos. There's a day planner called Chronos. Okay. Anytime you see chronotropic, you're thinking rate. Okay, you're thinking heart rate when you see chronotropic. So a positive chronotropic effect is going to do what to your heart rate?
Increase.
You're going to increase it. Whereas negative chronotropic effect is going to what? Decrease it, obviously. Very good. So here's why cardiac cells are sexy. Okay? They have 4, count them, 4 properties that make them really hot. Number 1, they're excitable. Oh, yeah, they are. Yeah, they are. They respond to electrical impulse. Did anyone go out and buy Dubin's? The extra book, that book about cardiology? Okay, one of the first chapters in Dubin's has a frog. And it's a dead frog, and they're applying electrodes to make the frog jump. That's when I stopped reading Dubin's. Because when I got Dubin's, I was a little tree-hugging hippie from Swarthmore, and I was like, oh my God, they're hurting the frog. I can't do it. But now that I'm a little bit less of a tree-hugging hippie. I mean, I do hug trees occasionally, but like only in my own time. You have to think about it. That's really a good example. Okay, so muscle is excitable. If you apply electricity or an impulse to cardiac muscle, it's going to respond. And that's something very specific to cardiac muscle. Conductivity is the ability to pass on electrical impulses. So not only are we going to respond to electricity, we're going to pass it along. We're going to share our wealth. Automaticity. Now this is like right here, this is swoon worthy. This shit is going to make you swoon, okay? It can generate its own electrical impulse. Oh my gosh. You've never swooned? You've never been in love? Have you never been in love?
What's that?
You've never been in love? You've never swooned?
Do I look kind of got
Aww.
I mean, come on.
Well, there wasn't one crazy.
So, again, automaticity. It's swoon-worthy. It can generate its own electricity. How badass is that? That's awesome. It doesn't need anything outside. The nervous system is going to control and regulate the heart, but it doesn't actually make the heart work. Why? Because the heart it has its own automaticity. That's awesome. I can't get any higher. That's as high as I go. Contractility is the ability to contract. That makes a lot of sense because it sounds that way. Contractility, ability to contract. Oh, kids. All right. So excitability, conductivity, automaticity, and contractility. The 4 best parts of the heart. The 4 things that make cardiac muscle sexy. Specialized conduction tissue. It propagates the electrical impulses to the muscular tissue. Okay? This is where we get really interesting. We're going to talk about pacemakers. Yes! Pacemakers set the rate for cardiac contraction. This is where we come up to cardiology cat. Okay? You got 3 major ones, 3 major parts of the heart, 3 major pacemakers in the site, or pacemakers of the heart. You've got your sinoatrial node, okay? You have your AV junction, and then you've got your Purkinje fibers. Those are your 3 major sites of the heart. 3 major parts. It's like conduction tissue. It's just like a big old wad of tissue that just kind of like, it clumps, and it becomes a pacemaker site in the heart. Now listen, pacemaker sites in the heart, they exist everywhere. Every foci, every collection of specialized material in the heart, connective tissue, has the potential to become a pacemaker site. Just because we have 3 major ones doesn't mean that the heart only has 3. Any ectopic site, meaning an area of specialized conductive tissue that can cause its own beat or cause its own impulse, is considered to be a pacemaker. It's just not one of the big 3. So when you put someone on the monitor and they have a lot of FLBs, funny looking beats, on the monitor and you don't know what the hell you're looking at, it might not necessarily be coming from one of the big 3. So now we got to figure out where the hell it's coming from. Are you guys okay? You never heard FLBs? Seriously? Listen, let me tell you something. Cardiology is my thing. Like, you know, I was kind of trying to trudge through Mod 1 because that shit is just awful. I'm sorry, it's horrible. I hate it all. I hate respiratory. I hate airway. I hate pharm. Cardiology is so my thing. I love it. It's awesome. I mean, seriously, how can you not get excited? We have fingers in the heart. Ah! And it all makes so much sense. Okay, look, right? So when you're looking at the monitor, right, you hook up your electrodes to the monitor. You guys are just having a blast.
I can't pick my head up because it's just like too much. It's too much sensation.
Listen, it's too much sensation.
I can only use so many senses at one time, and you're taking all of them. And it's like, you can't.
Why are you blushing?
I don't know. Like, I'm just trying to think of all the senses. Like,
I got lots of
I mean, I have perfume on.
Yeah.
All right, I did the deodorant. All right, ready. So let's talk about this. When you're looking at the monitor, we need to know what you're seeing and how it's correlating to what your heart's doing. So let's talk about that for a second. Let's talk about how your pacemaker sites are going to be so important and how we are going to look at our monitor and we're going to figure out what our heart is doing based on the monitor. This flag has to go. Because I like drawing right here and the flag is like right here. I dislike it.
Problem with America?
I don't have a problem with America. I have a problem with the placement of the flag. All right. So this is your P wave, okay? When we're talking about the P wave, we're talking about the depolarization of the atria. Okay? So if we have a change in the morphology, or essentially the shape of our P, what do we know? Come on, kids, hold it together. She said TP. All right, so atria, if we have a change in the morphology of our P wave, what does that mean?
Atrial problem.
We might have an issue of our atria. We might have atrial damage. We might, maybe we have an ectopic foci that's actually not part of the SA node, but it's starting to generate its own thing, okay? So there's something happening that's not quite right in the atria if we have a change in our P wave. Our PR interval right here is depolarization of the atria and a delay at the AV junction, okay? So it's kind of, it's moving from the top on down. It's kind of starting that depolarization process down. QRS is depolarization of the ventricles, okay? So atria, ventricle, atria, ventricle, atria, ventricle. Okay, so if we have change in the QRS complex, what do we have an issue with?
Ventricle.
Our ventricles. What if we have a really wide QRS complex?
And it's taking too long for the ventricles to contract.
There's something wrong with the ventricles, absolutely. Okay, there's more happening in the heart, lower in the heart. Listen, lower is slower, lower is wider, lower is bad. We want to stay up high in the heart. When you're up here at the SA node, you're healthy. Lower you go in the heart, the slower you're going to go. And the lower we go in the heart, the wider the complex is going to get with regard to your QRS. In fact, let me show you this real quick. Okay, these are your rates. These are your rates for the big three. Okay? So again, when we're talking about our big three, pacemaker sites, the lower you go in the heart, the slower you're going to get. SA node way up here. The rate is going to be 60 to 100. When you come down a little bit lower, again, your heart rate's going to drop. You're going to go 40 to 60. And then way down here in the junctions, right down here, you're going to be 20 to 40. That 20 to 40 rate, what does that Purkinje fiber, what does that innervate down here?
Ventricles.
Your ventricles. So your normal ventricular rate is 20 to 40. Can that sustain life for very long?
No.
No. So someone raise their hand and say, but Danielle, I thought ventricular rates were really fast. Do it. Just humor me, someone. Ventricular tachycardias are, yeah. But not everything that is in the ventricles tacks. Okay? Everyone comes in with this preconceived notion that ventricular tachycardia is the only thing down in the ventricles that we're going to see prehospitally on a monitor, and that is flat out wrong. Okay? We have a lot of intraventricular rates down there. We have a lot of different things down there that live down there that we need to be able to identify. So, when I put tachycardia or bradycardia on the end of anything, it means fast or slow. So ventricular tachycardia is fast ventricles. Okay? 20 to 40 cannot sustain life. What about 40 to 60?
Maybe.
Potentially. Some people live all their lives from 40 to 60. Okay?
Very healthy.
They're really, well, like, it could be either way. They could be really unhealthy or really healthy. Okay, absolutely. But my point is, there are multiple pacemaker sites in the heart, and these are just the big three. As you progress through cardiology, you're going to find out about all kinds of different weird little things all over. These little ectopic foci. And we're going to talk about different beats, PVCs and PJCs and all kinds of PP, premature atrial contractions, premature ventricular contractions, premature junctional contractions, and we're going to talk about all these little funky ectopic foci that are going to generate their own thing, and they want to do their own thing. And sometimes you got to go up and smack a bitch. You got to say, no, you can't do it. You can't do it. Look, I got you to look up. So absolutely. Sometimes you got to go up to this ectopic foci and say, hey, stop. You can't do that because you're causing damage. Okay? So again, when we're talking about pacemaker sites, how many pacemaker sites do we have in the heart? My guess. Huh? Yes, you do. Look up at the board. How many pacemaker sites do we have in the heart?
3 major ones.
3 major ones. But we have a lot of other pacemaker sites. It is a trick question, yeah.
What?
We have 3 major pacemaker sites in the heart. Okay? And you need to know those big 3. SA, AV, and then down into the junction. You guys need a break?
Break it up.
Yeah? All right, go take a break.